Right. Good evening, everyone. Lovely to have everyone join us. Welcome to the next rural onboarding webinar, and we're very privileged to have Prof. Adeniyi, who is the head of family medicine and emergency care at Cecilia Makiwane Hospital in East London, and he's also an NRF C2 rated researcher who supervised many MMeds and supports many doctors with their research. So we're going to be looking at some HIV topics. This week is all about infectious diseases. And Prof, we're going to hand over to you. Thank you very much for giving us this talk. Prof, can you hear us? Maybe just some housekeeping while we just wait. He might have just had to step out. If you can just check that you are muted and your videos are off. I see someone's got their video on at the moment. If you can just check that. And then a reminder that your CPD points will be available once you complete the poll at the end of the session, and that will come up. Prof, can you just mention if you can hear me and whether you are able to start your presentation? You see me? Can I ask you if you can just contact Prof and just see if there's a problem? And there's someone, Gear Krishna, with a video on.
Can you hear me?
Yes, we can hear you. Fantastic. And thanks, Prof.
All right,
Yeah, go for it.
Can you see my slide?
Yes, we can.
Okay. When we are ready, let me know.
Okay, we've just done an introduction, so over to you.
All right. No, thanks very much, Dr. Nach, and welcome to all the people on the platform. My job here is very simple. It's just to give us an update on what is new with regards to our prevention packages for HIV, especially in the country. But again, we need to equally draw from the best practices that are available in different parts of the world, but more importantly, what may come in the very near future. Currently, there's quite a lot to talk about over the next hour. Then we'll gradually unpack the various aspects of the prevention packages. But more importantly, I will focus on what I will consider new information with regards to this particular topic. But that does not mean that we will not in any way give credence to what we already know and what we already doing with regards to prevention of HIV in our day-to-day practice. These are the documents I've looked at in terms of putting this together. The only outstanding one was the newest guideline on the long-acting lenacapavir that was released in December, so which again has been included. It's important that we understand why we should care about issues of prevention, because as a country, we have a very large number of people living with HIV, with prevalence estimated at above over 17% for the general population, and predominantly women seems to have the worst off with regards to the disproportion in the prevalence. And also, we noted that over 90% of the new infections that are occurring currently are occurring in adults, and therefore that should be our priority for HIV prevention, given that we as a country there have been a lot of investment into reduction or maximum reduction in vertical transmission from mother to child. And therefore, the 90 infection occurring at the moment are occurring in adult population, predominantly driven by sexual activity. And therefore, we need to be looking at the composites of all prevention strategies that can assist in bringing down the number of new infections, within the country. As you can see, with regards to the 95 units target, South Africa as a country has done significantly well, as you can, as evidenced by the data published by UNAIDS South Africa, and which has consistently shown that more than 95% of the people who are currently living with HIV in South Africa have actually been diagnosed. And the implication thereof is that the remaining 5% still needs to be diagnosed, because what evidence has shown currently is that those who are living with HIV undiagnosed are the will continue to spread the virus. Those who have been diagnosed and linked to care and are achieving virological suppression are less likely to transmit. And that is a key message that we need to incorporate into our messaging during consultation with our patients. As you can see, the epidemic in South Africa is changing. And this is a DHIS data looking at over a 2-year period, the proportion of new infections per HIV tests done. As you can see, consistently over a 2-year period, the new infection, the new diagnosis rate has dropped below 5%. As you can see, this trend is continuing. You need to test about 100 people for you to diagnose 2 to 3 people, which is a testament to all the investment that we put, into HIV management over the past 2, 3 decades, and is beginning to yield dividends. But what does this mean in terms of approach to HIV testing? We are familiar with our rapid kits, and this algorithm is what we've taught for more than almost 2 decades now, in which when the prevalence was high in the general population and fewer people were testing, we needed, just one single confirmatory test was enough for us to confirm diagnosis when prevalence is high in the population. But the implication thereof is that as more and more people have tested and linked to care, and now we are only looking for the remaining 5%, which therefore means if you put the absolute number over the rest of the general population of people in the country, it therefore puts the prevalence to far below 5%. And therefore, a single confirmatory test is no longer, considered appropriate. Otherwise, there will be more false positive results that will be emanating. And that has led us to what we call the WHO 3-step testing algorithm. Okay? And what does this really mean in practice? No, going from what we used to do, okay, a positive or a reactive screening test previously will be diagnosed, will be confirmed with another kit from another manufacturer. And if both of them are reactive, we will simply report that patient as having HIV. Okay? But now we are basically saying that given the number of people we need to search for, among the rest of the population that have not been diagnosed, that have not been tested, or are currently negative, we need to confirmatory test to bolster the diagnosis of our patient, so that we want to cut off any chance of false positive rate in the population in our tests, HIV testing algorithm. And therefore, for you to then say that a patient is having HIV, we need to have 2 reactive confirmatory tests, each of which must be from a different manufacturers. Okay. Now, seems pretty straightforward. We'll pick a screening test. If it's positive, you pick the first confirmatory test from a different manufacturer. You test again. If it's negative, if it's positive, then you confirm again with another confirmatory test before you can record that patient as HIV positive. However, if the screening test is negative, you simply report the person as negative. Give these rapid tests, it is actually very, very sensitive and is able to pick up all the infections in the patient. However, if the first confirmatory test reports as non-reactive, we would then simply have to pick another screening test. Okay, the one we used initially, we'll pick another test kits and repeat the test. Okay, if the test is negative, that individual definitely will be recorded as negative. However, if repeat test is positive, then we will have to record that as a discrepant result. And therefore, we will now have to pull blood of the patient and send to the lab for confirmation. Again, if the first confirmatory test here is positive and the second confirmatory test is negative in the patient, we will record that patient as the result, as discrepant result. And both of these scenarios will require confirmation from the lab. So it's important that we take cognizance of this new testing algorithm, which requires 2 confirmatory tests for every initial positive screening test before you can label the patient as having, HIV diagnosis in our patient. Now, if the result is inconclusive, we will simply have to bring the patient back, as early as 2 weeks for the test. If the ELISA, reports inconclusive result, okay. And also, it's important that we are able to translate these new changes into the various testing category. As you know, all children under 18 months will have to be tested using PCR, but children between 18 and 24 months, we will screen with this new testing algorithm, and if the result is positive, we'll simply have to confirm with PCR. And definitely children from 24 months and above will have to follow these new testing algorithm. So this is a new information that's been published for us to start implementing, from May 2025. Now, with the options of pre-exposure prophylaxis and looking at addressing issues of equity and access to pre-exposure prophylaxis for all our patients, you will know that HIV self-testing has equally been brought into the picture. However, these should only be considered for oral preparation as well as dapivirine vaginal ring, which I'm going to talk about shortly, but not for long-acting, injectables. Okay, and it's important that if any individual patient purchased a test kit from Clicks or Dischem and has tested himself or herself at home, we still expect them to be linked to care. They need to come to your facility, and it's expected that you are going to follow these 3-step HIV testing algorithm in terms of confirming whatever report your patient may have given you. Okay, we don't simply take the report of the patient that she tested at home and then start acting on it. We expect that you still follow the normal process and do the needful. Now, with the long-acting, injectables, it's important. There are some new concepts we are going to cover, which brings attention to use of nucleic acid application test or pulling blood for viral load as part of the confirmatory tests that are needed in some of the, because of the what we call the prolonged tail phase of the long-acting injectables. And now the focus of our talk for today is largely around pre-exposure, but more importantly, looking at what is available in the market in South Africa and what has been approved for use by both SAPRA as well as ECDOH. I put some question here as a teaser for us to just, first of all, let's reflect. What are the options of pre-exposure prophylaxis that are available where we are currently practicing? But again, whether you are in the public sector or you are in the private sector, we are working serving the same community of people living in South Africa, and therefore we cannot be ignorant of what is happening down the road next to where we are working. Now, the big question, if you look at previous guideline 2016, 2021, the specific category of people were labeled as high-risk individuals that are prioritized or high priority individuals for pre-exposure prophylaxis. But the evidence is moving very fast in this regard because any individual who walks into a health facility and requests pre-exposure prophylaxis, such an individual must have considered his own personal risk as being high or significant enough to warrant that such individual wants to go on a medication for prevention of HIV. And therefore, as clinician, our focus going forward is to now look at how can we assist such individual patient to mitigate his risk or ongoing risk of exposure to HIV, while we would then assess such individual for eligibility for, having provided all the options of pre-exposure prophylaxis that are available in the whichever facility we are practicing, but equally, we must equally educate patients on other options that they may have capacity to be able to secure in private. And therefore, the talk this evening is not limited to what is available in the facility where we are practicing, but broader community in South Africa. So I've provided a whole list of what our guidelines have indicated as considered a priority population, but that does not mean that any individual who may not fall into this category can be dismissed from the facility. As a matter of fact, any individual who engages in any form of sexual intercourse, intersexual exposure, will benefit from pre-exposure prophylaxis. Okay. If we look at the journey, there have been several guidelines. I only saw this one just recently, the latest publication from December, and I'm not sure if everyone has seen the document. Okay, but I took some liberty to add some additional information on lenacapavir because now Department of Health has actually produced specific guidelines for lenacapavir. We are still waiting for information with regards to medical aids, whether they will cover lenacapavir, but given that the cost is still prohibitively very high at the moment. But the good news is the global funds subsidized and donated some doses of lenacapavir to the country, which will soon be rolled out. Now, whichever option of prophylaxis that is available, it's important that the gateway of access to pre-exposure prophylaxis still remains HIV test. One major contraindication to giving any patient pre-exposure prophylaxis is any individual who is either unknown status or already having HIV. Therefore, such individual, anybody within that category needs to have HIV test done. But more importantly, we recognize that some individual may be at risk. They may be seroconverting and may already have features of acute HIV infection. Such information should equally be gathered in our patient. We need to be able to screen, do symptom screening for acute HIV infection in our patient, especially for patients who may have elected to go on long-acting injectable, in which case that any viral breakout will then be suppressed by the medication on a long term. And therefore, the HIV diagnosis will be delayed in such individual patient. It's critical that we are able to assess the risk of every patient and be able to profile every patient depending on the request of or option of pre-exposure prophylaxis they are demanding when they come to our facility. Whichever option we are patient will choose, we must familiarize ourselves with appropriate pre-choice counseling. And it's important that, risk assessment is critical. Looking and every patient in front of us is unique. And therefore, while we have general understanding of the drivers of HIV, the person in front of us, we must show interest to understand what are his or her risk. Vis-a-vis, when was the last exposure? If some individual has just been, maybe somebody had a casual exposure, casual sex over the week, maybe on Sunday night, such an individual will not benefit from pre-exposure prophylaxis, even if the HIV test is negative now. Such an individual should be immediately initiated on post-exposure prophylaxis while you then provide counseling with option, plus option to transition such an individual patient immediately post-exposure prophylaxis to pre-exposure if the risk is an ongoing situation. And it's important that we do not focus on pre-exposure prophylaxis as independent of the rest of the prevention packages. As you can see, barrier methods should always be emphasized in our patient. Partner testing, very, very critical because the person who is negative, if the partner is positive and all the necessary precautions are not taken, then the risk may not be completely attenuated. Again, voluntary male medical circumcision should equally be, discussed and offered to our male patients. Post-exposure prophylaxis, again, we need to, an appropriate individual, such may be what they will qualify for. And therefore, all of this information should be part of what we have in our prevention kits so that when patients come, we can quickly stratify and then provide the best care for our patient. And we equally must know the pros and cons for every information, every pre-exposure prophylaxis that is available. This is just to detail what we've got within our prevention kits. Okay, those it's important, this category of individual, those who use drugs and or those who inject drugs, it's important that we equally recognize the dual risk of HIV transmission in this category of patients. They equally engage in sexual intercourse. They use drugs and still engage in sex. And therefore, the risk in this category, is enormous. And therefore, it's important that we, conduct full risk assessment so that we can have full understanding of the patient in front of us. But also within this prevention package, we will see that the department recognizes that if for women in reproductive age group, HIV, pregnancy tests needs to be done, and if positive, needs to be linked to antenatal, and if negative, therefore we need to be inquiring about future fertility desires, vis-a-vis, initiating such patients on contraceptive. We equally must include TB screening, mental health screening, and use the opportunity to screen for intimate partner violence, which is a major issue in the country, okay, and provide necessary linkage to social worker and psychologists as be, okay. And of course, as current STI screening, vis-a-vis partner notification and treatment are critical part of what we are expected to cover when we see our patients. Again, we must be flexible when we talk to our patient. We must not be seen to be passing judgment, okay, when we conduct consultation for our patients. Because you are going to see elderly people come to you for this pre-exposure prophylaxis. You are going to see teenagers come to you, and therefore you are expected to provide professional counseling, and the guideline detail all the core component of the expectation. Let's get to the meat of the discussion. Oral pre-exposure prophylaxis, Truvada, as popular everybody knows it to be, but it's mostly tenofovir and emtricitabine combination. It's available everywhere. It's been in the country now for close to a decade, and particularly pleased that the uptake rate have been reported to be close to 2 million across all the facilities. Almost 90, all the PAC primary health care clinics have got pre-exposure prophylaxis, according to the data that was reported in this guideline, which is quite refreshing. And it is our job to push during our consultation to make sure that those who are currently HIV negative can access this medication through information sharing. Who is eligible? Those who are over, who are at least 30 kg and above, definitely more than 10 years. But again, Children's Act comes in. No child under 12 can have sexual penetration, so that we must equally be able to screen for ongoing statutory rape, which may be a concern. So please take note of that. Efficacy has been proven conclusively, as you can see, but it's important that our patient is aware that once they start Truvada, or the other alternative, which you will see in the private sector, which is TAF, tenofovir and lafenamide plus emtricitabine, 25, 200 milligram once a day, okay, which is available in the private sector. That allows such patients, even GFR of above 30, below 50 up to 30, can use the second option, which is that, okay? But any individual, let's take note of the GFR requirement for children under 15 years. We expect them to have perfect kidney, okay? So eGFR should be above 80. And in pregnant women, we want the absolute creatinine level to be more, the serum creatinine level should be less than 85 before they can use it. So all of these are contraindication to giving Truvada to a patient. Within the first 7 days of initiating the pre-exposure prep, they must use barrier method, okay? They must use condom for the first 7 days. Beyond 7 days, now they are safe, okay? So it's important that we are aware and we can share this information. The side effects are generally very mild. Few patients may report nausea, diarrhea, headache, and dizziness, but these are generally very mild. It's well tolerated. So now, how do we follow up this patient? Having screened them for HIV and they are negative, we've screened them for hepatitis B, because that's equally very important in terms of concentration for when patient will stop the treatment, so that we want to prevent acute flare. Okay. Um, we following initiation, because we want to bring the patient back within the first month so that we can reassess the risk of our patients, ongoing risk exposure, vis-a-vis repeat HIV test in the patient. Okay. And then if the patient remains negative, we will then issue 3 monthly scripts. And every 3 months, such patients needs to come for review, in which you assess adherence in the patient and also offer HIV tests at every visit, and therefore you renew the script. But please note, if the patient tests positive, may largely due to people not missing doses or not taking the medication as they should. Definitely, that's a concern, and such an individual patient needs to be linked with ARV clinic or to be initiated on full ARTs for treatment. And of course, if the GFR of the patient drops, that definitely is a concern for us to make a decision to stop. Okay, and any patient, any individual who is consistently not using the treatment or who no longer considers himself uh, as at risk. We see a lot of young ladies, if they're out of relationship, they will stop contraceptive, they will stop this type of medication. But it's important that we are able to counsel them and make it assist them to stop the medication safely. For instance, if the patient has been screened for hepatitis B and is positive, both medications tenofovir and tritamine have effect in suppressing the viral load, the DNA viral load of the hepatitis B. And therefore, any abrupt stoppage will lead to flare of the hepatitis B. And therefore, it's important that we are able to assist our patient and counsel them to make a decision as to whether they will continue the Truvada for the sake of their hepatitis B. Otherwise, we may then have to monitor and guide them to make a decision on the best time to stop, in which case we will have to see that the viral load, the hepatitis B surface antigen sequence has actually become negative, or the titer has dropped remarkably, in such an individual patient. Okay, and even after that, we will still have to monitor the patient for at least a year, looking at the viral load as well as the ALT level, so that we can pick up when acute flare is beginning to develop. As you can see the data there, evidence has shown that a remarkable, a huge number of our patients will develop, acute flare within the first 2 years of stopping the treatment. Now, it's important all the core issues to be covered during follow-up of our patients. We want to review the adherence of the patient. That's the most critical, and that's the most important determinant of efficacy of this medication. Of course, side effects could be a concern, and we want to address and manage this for our patient. And of course, if there are any other concern the patient may have, we will want to deal with that in our patient. So please take note of all the structures. If we look outside of our guideline, you will see that some people may ask you about what we call use of oral prep, or what we call on-demand or event-based prep. Okay, we cannot claim ignorance of this kind of information, because some of the patients we equally have access to information online, and they will ask you in your consulting room, and you need to demonstrate understanding or awareness of these concepts. Okay, the Southern African HIV Clinician Society has published this, so that, which means people in private can offer this to our patient, and patient may equally ask you. We are hoping that in the near future, the EDL will equally incorporate this into the practice. What does this mean? Evidence, head-to-head comparison, has shown that when, especially people who are not in stable relationship, especially, they often don't see it to be on medications every day. But there is what we call 211 method or extended on-demand PrEP, which I'm going to cover. But essentially saying within 2 to 24 hours, if a patient, an individual client takes 2 tablets of Truvada and then have exposure to, anytime from 2 hours after taking the medication, and then 24 hours later, a single additional dose is taken, and 48 hours later, another dose is taken. That 86% risk reduction overall was reported in a number of studies. As you can see, even one particular study reported 98.6% risk reduction in the risk of transmission per episode. So please, we need to be aware of this. Okay, and this is a schematic picture showing for a single exposure, provided 2 tablets is taken 2 hours before, and thereafter must be followed with 2 additional doses, 1 tablet a day for 2 more days. Post sexual exposure, there is, the efficacy is quite great. Again, for extended exposure, you know, these, again, you see here, 2 tablets, 2 to 24 hours before exposure started. And if the person has multiple exposure, for example, somebody traveling to visit a partner in Johannesburg for a weekend, in which case Friday, Saturday, Sunday, we would then expect that the person will start the 2 tablets of Truvada before engaging in the journey, and then exposure can continue, but they must make sure that 24 hours after the initial dose, they must take 1 tablet after every 24 hours and continue with 2 additional doses after the last sexual exposure. And this, again, is supported by evidence. The UK guideline has got this, US guideline has got this, Southern African HIV Society has equally got this, but our National Department of Health has not incorporated this. So please watch out for this. But again, you must be aware that there's something like this. Again, 2-7 dosing schedule is equally been reported for women, okay, and for a total of 9 doses. And this is likely because the concentration in the vagina is not as great as in comparison to anal area, anal mucosa. Often than not, we're concerned about effectiveness. It's always there. But nonetheless, these are equally been shown, okay, in studies. But Southern African HIV Society is still reviewing the data watching this. So please be aware. For pre-exposure prophylaxis for people using drugs or who are injecting drugs, it's important that we are aware that there are multiple risk factors involved in HIV transmission in this particular population. And therefore, it's important that we do not look at PrEP in isolation of the comprehensive harm reduction package that this individual person needs. Okay? And the popular Bangkok tenofovir study actually demonstrated just barely 50% reduction in the risk with use of daily oral PrEP in this particular population. And this, the risks are multiple, and there is no data yet on the long-term injectable for this particular population. So please, we need to look at the composite of harm reduction plus pre-exposure for this particular population. The pivirine vaginal ring is not yet in the public sector, but is available in the private sector. The pivirine, I'm not sure if everybody is familiar with the pivirine, and therefore it's important that we recognize that the pivirine belongs to the same class as the favirenz, nevirapine, ripivirine, etravirine. So they are all non-nucleoside reverse transcriptase inhibitor, and we know that it works. Okay, but essentially it provides is a ring that women can put inside the vagina, and it stays there for a month, and it gradually releases pus, what appears like a topical kind of microbicide in which it prevents viral replication and within the vagina of the patient, and therefore prevents gaining entry of the virus into the body of the patient. So this is particularly a good option that is available in the private sector. Um, but it's important that we know the limitation, especially in regions that have got a lot of HIV, HIV-2. As in West African region, this will not be a good option because efficacy is not been proven. And just like all the rest of the class of NNRTIs, HIV-2 they are generally not effective against HIV-2. That is what a veteran looks like, you know. And interestingly, there's quite a lot of interesting things, in the near future around this, because now they are beginning to incorporate contraceptive levonorgestrel with dapivirine as part of dual protection for pregnancy and HIV for women as a way of improving or marketing and improving access to acceptance of this particular product to women. Okay, it needs to be kept in the vagina for 28 days, but its effectiveness starts after 24 hours of insertion, and we need to be able to educate our patient around this. Okay. Pregnancy, it's not generally recommended. Again, as you can see, the risk reduction is not as great. We want a foolproof, PrEP in pregnant women. Okay, and therefore, we is generally safe. If it for any reason there is an expulsion, if it's expelled in a clean environment, it can simply be rinsed with clean water, and the client can reinsert it. Otherwise, she might need to come back to the facility to get a new one. But otherwise, it should be replaced every month, and it's ready to go after 24 hours. The side effects are generally very minimal, as you can see, and they are things that can be managed. What is new for essentially, especially, is the lenacapavir, which I'm going to talk about. But again, cabotegravir has been available since 2021, and the guideline was published. I'm not sure because even in our facility here in East London, we still do not have cabotegravir as a prevention pill, or tool for use. But we are, there will be more investment into pre-exposure prophylaxis by the government and through donor agencies. We expect that all these medications will become readily available. So the cabotegravir is an integrase strand transfer inhibitor, which is in the same class as dolutegravir, raltegravir, bictegravir, elvitegravir, all of that are in the same class of drug. Okay, and therefore, if you remember, all dolutegravir, they all work through the same mechanism. Okay, and these in terms of dosing, the it's an intramuscular injection, 300 milligram, which comes as 3 ml. Okay, the leading dose. There are two options. Okay, depending on whatever product that is available or delivered to the facility, we need to familiarize ourselves with the initiation injections. The first dose is given. If the first dose is given today, in 4 weeks, a second dose will be given. Those two initial doses are considered as leading dose for or initiation injection for cabotegravir. However, after the first 2 doses have been given, then subsequent follow-up repeat injections will be given every 2 months. Please take note of allowance of 7 days window, which means 1 week before the due date, a patient should be canceled if your employer is not going to release you on a particular date. Within 7 days before your due date, or maximum of a week after your due date, you can come and get your injection. That is the best way to cancel our patient for this. But there is also what we call oral leading dose. Cabotegravir oral tablets of 30 milligram can be given for a whole month, which equally allows us to assess the tolerability around the side effects of the cabotegravir for the patient, and therefore we can then proceed to give the cabotegravir injection thereafter. And typically, if patient tolerates the tablet, then within 3 days of the completion of the first month, that patient should then come forward and get the start dose of the medication. That is the way it should be given. So whichever one, whether we give 2 injections, 4 weeks apart as our loading dose before we move to 2 monthly injection with allowance of 7 days there, or we give an oral leading dose of 30 milligram for the first month, and the injection would then be given within the last 3 days of the oral leading tablets. Thereafter, the patient can then go on the injections and then continue with 2 monthly injection thereafter. But also, if a patient anticipates that there may be delay for him or her to come for the next injection, there is always an opportunity for us to then provide cabotegravir tablet 30 milligram daily for a scheduled period of time, and in anticipation of missed appointment as a bridge so that the patient does not have erratic use of the medication. Everybody qualifies. Everyone will benefit from cabotegravir if you are HIV negative, but your weight must be at least 35 kg, and also it's been shown to be efficacious in pregnancy and safe in women. And these, as you can see, efficacy is actually as high as 100%. Okay, and therefore we must be counseling our patients with regards to choosing one of these injectables, and we hope that all of these injections will be available very shortly in the various facilities. The side effects are equally very tolerable and very minimal so far based on clinical trials. But again, as we begin to roll out these medications, we then need to monitor our patients on the long term so that we can pick up if there are additional side effects that have not been reported in clinical trial. One key issue, especially in South Africa, is TB, rifampicin, rifampicin, rifabutin, as well as carbamazepine, phenytoin, and phenobarb will induce the cabotegravir as well as nalacavir below the therapeutic level, and that is a concern. And the key recommendation thereof is that we want to make sure that our patients who are on TB treatment will rather choose the oral. We will choose oral PrEP for them, pending the time they will complete their TB treatment. That would be the preferred choice. And if patients having, they are epileptic, we will then find a way to transition them to lamotrigine if they are going to go on this. And all of this should be discussed with our patient. This is basically providing you a schedule, or now patients should be reassessed and follow up with our patient. It's a deep IM, as you can see. These are the regions where whether we give it in the ventral surface of the thigh or you give it in the usual space where we give injection. That is the preferred side. The side effects are minimal, as you can see.
Can
Injection
I just say
sites.
we've got 10 minutes left?
Okay, so the side effects are very minimal, and I will quickly touch on the fact that 8 weeks, once injection is given, is protective for 2 months. And therefore, if your patient is going to stop the medication, we must then provide we need to cover the tail because of what we call Levi syndrome. As you can see, the medication remains at lower concentration for 12 months, and therefore will prevent uh, you know, the viral load of the patient to go up, and that may impact on diagnosis or delay diagnosis. So if anybody is going to stop the medication and the risk is still ongoing, it's better we transition such an individual on oral prep for to prevent resistance developing. There's quite a lot that you please look at the EDL, the essential drug list, PAC level. I've got all of this additional information so that you are able to capture that. I want to spend the remaining 10 minutes on this one that has got everybody by the whole world buzzing. That's lenacapavir. Lenacapavir is a multi-stage capsid inhibitor. It's a novel drug. It's the only drug so far in its class that's just been developed. It's a subcutaneous injection which is given every 6 months. And if we want to read more, as you can see, and purpose through clinical trials, as you can see, South Africa contributed into the participants that inform the science governing this particular product. Okay, and efficacy is on the minimum 96 to 100%, as you saw there, and that led to WHO adopting this developing guideline for lenacapavir, and South Africa has equally released and published this document in December. Please look for it and go through it so that you can pick up on the practical aspect of how lenacapavir should be administered. It's been registered again in South Africa now. It comes as oral tablet, 300 milligram tablets, and then injection with now the ampoule is 3.5 milligram of 1.5 ml ampoule. Okay. As you can see, this drug works at multiple level. Okay, towards prevention of viral replication. That's the mechanism of action. We want to cover that. But the approach to this patient is that every patient that will go on lenacapavir must have been attested, and HIV must be excluded before you can put any individual on lenacapavir. Given the long duration of action of minimum of 26 weeks, 26 to 28 weeks in the patient, it's important that we equally assess the potential chance that an individual may still be within the window period. As you can see, if the patient has got fever or is going ongoing rashes, has got lymphadenopathy, such an individual patient, you may need to provide the offer barrier method for the patient and bring the patient back in 4 weeks and retest the patient to be sure that to be to be sure that the patient would not already have been incubating the virus. And that's very important so that such an individual patient does not then go on lenacapavir and then remain develop Levi syndrome, which can then be diagnosed only when the patient stop the medication. The good thing about lenacapavir, because of the novelty of this drug, it will knock off any resistant virus in the body of the patient. It will prevent any no resistant virus can gain entry with lenacapavir because nobody has been exposed to this new class of drug. And that is the novelty of this drug. Again, like lenacapavir, you must be 35 kg and above before you can use it. Now, in terms of how the medication should be initiated, this is a typical way which has been, good for us to be able to see. We have to give the patient on the first day will get 2 injections, okay, which must be separated by at least minimum of 5 centimeters apart. Each ampoule will be withdrawn in different needles, syringes and injected, but the individual patient must equally get 2 tablets of 300 milligram starts with the start injection, plus the following day, 24 hours later, the second 2 additional tablets of 300 milligram, must be issued. That will give the loading dose for the patient. And thereafter, this patient must be brought back in 4 weeks' time, reassess the risk of the patient, retest the patient for HIV, and then we can then get the patient back for 6 monthly injection. Okay, it's important that the patient knows that after the start dose, you must wait for days before your exposure. Or if you will have exposure, then you must use barrier method in the first 2 days, so that by third day, it will then reach effective level. Okay? So it's important that all of these counseling are provided. Side effects are mostly limited to injection site in form of erythema, swelling, duration, and occasional mild headache, nausea have been reported in the literature. Again, so far, anticonvulsants, the traditional anticonvulsants will be a problem, as well as rifampicin is going to be a problem. So if any of our patients fall pregnant on, could develop TB on this medication, we will have to provide additional protection. Either the patient barrier method, or better still, we have to go on oral Truvada for the period for at least 2 weeks after they've completed their TB treatment to make sure that the concentration level is not grossly impaired and can lead to HIV transmission. It's important as part of our workup that like we did with all the other injectable STI screening, pregnancy test, contraception, TB screening, all of that should be done. The guideline itself have just given guidance on how the preparation should be made, which is very simple actually. Okay, it's a clear ampoule with a vial, and you have to withdraw. But more importantly, the small 22 gauge needle would then be used to administer it. And where are we going to administer? The preferred location is the abdomen. Okay, and you have to pinch up just like the way your insulin is. Those who are giving insulin, they are familiar with this. And we as clinicians, we cannot be ignorant of this, because it should not be given deep IM. Okay, it's not intradermal. It should be given under the subcutaneously. And these are the various sites: abdomen, in the thigh, as well as the posterior part of the deltoid area. So those are the sites where it should be given. Okay, the follow-up messaging, there including side effects. If they are concerned about the patient, you want to reinforce, risk stratification, discuss other modalities of prevention with our patient, and also listen to the patient if there are other concerns, then, so that at least we're able to assist our patient. It's important that only allowance of 2 weeks is given in this patient. If patients comes 2 weeks post next appointment, therefore you have to then restart again. In which case you have to give the leading dose of 920 920 sorry the 927 milligrams, of the injection plus the 2 tablets, which must be given as loading dose before you then continue 6 monthly injection. Okay, a couple of other issues for everybody to be aware that this medication is actually, is equally being considered for treatment experienced patients. It's not just only prevention. In the near future, there are studies showing efficacy in people who are already suppressed, who can then be transitioned to lenacapavir. Okay, so there are quite a lot of opportunities in the future. They are equally looking at even once a year depot preparation of lenacapavir. So the Global Fund are subsidized at $60 per year, which comes to about 1,000 rand. And I think the rollout date is going to be in April, but we will still need to monitor. Okay, and I think there's approval for generic forms so that we should equally bring the prices down by 2027 to $40 per year. Okay, so those are, and there are a whole lot of other products like the vaginal ring for 3 monthly vaginal ring is equally being investigated at the moment. So we all should be excited about this new preparation, and then I trust we have picked up one or two things, and we can go back and look at the document, the guideline itself, and therefore we should be ready to assist our patients better going forward. Thanks very much, everybody.
Thank you so much, Prof. That was excellent and a really great overview. And as you've mentioned, it's so important for us to become familiar with these products. So as we hear people talking about them, as they become more available, we'll have some knowledge. And thank you for referring to the documents. One just quick question. Do you think I know with the lenacapavir, they've mentioned the skin nodules as a side effect. Do you think this is going to be a problem if you think about young girls who wear, shirts or tops that expose their abdomens? And do you think this could be a potential barrier to using the lenacapavir?
Yeah, no, thanks for the question. I think it's something we will need to monitor, because again, we don't have any experience so far. Okay, generally the nodules are considered to be very mild, but it's something we will need to monitor as we have more data on this. I think the only country in Africa so far is I think Swaziland is Swatini, right?
Yeah.
That I think they are the only one that have rolled it out so far. So I think hopefully we can join, and then we will be able to gather our own experience on this particular drug. But it's something to look out for.
Great. So there are lots of research opportunities coming up for those who need MMeds. So participants, thanks very much. Please, if you haven't completed the poll for your CPD points, please do so. I will keep it up for another minute or two. And just finally, just Prof, again, thanks very much for your time and very detailed presentation, very informative. We thank you for your time, and thanks colleagues for joining. We hope it was informative, and hope everyone has a good evening.
Thanks very much for sharing this session as well. Thank you. And good night, everybody.
Thanks, Prof. Thanks. I'll leave the poll up for another minute.
Bye-bye.
Bye-bye, everyone.